Hi, my name is Dr. Robert Coffin, and we're about to go beyond the Terminus. Today we're going to talk about case difficulty assessment. How do you determine whether a particular case is something that you should be treating, or whether to refer it out for treatment? For this video, we're going to limit our discussion to initial treatment of cases. I will discuss retreatment in another video. One of the most important skills you must gain as a clinician is how to decide whether or not the case is within your capabilities. And this doesn't apply specifically to endodontics. It could be for any specialty type of treatment that you are considering. Let's examine what information you need to assess before deciding whether to attempt endodontic treatment of a tooth. The American Association of Endodontists has published a case difficulty assessment form, which you can see here. And you can download it from my website, www.endoexperience.com, in the Endo Files section. Just search for the AAE Case Difficulty Assessment Form, and it will appear in your search results. You can then download the PDF from my site for free. You don't have to use the form on every case that you do, but it's a useful tool to help you examine difficulty and place the case in one of three categories: low difficulty, medium difficulty, or high difficulty. If you're an experienced clinician and are confident in your endodontic abilities, cases with low or medium difficulty are probably within your range. There's always going to be exceptions. If you're less experienced, you don't feel confident in your ability to handle the more difficult cases, or simply you don't like endo, referral is probably the best option for both you and the patient. Let's briefly go through the parameters of the form and the information that helps you make that decision. We're going to assume that you've done the usual due diligence when it comes to the patient's systemic health and ability to be positioned in a manner that allows you to work comfortably. The first criteria is diagnostic certainty. Are the patient's current complaint, signs, and symptoms consistent with the clinical tests that you have performed? In other words, are you sure of the diagnosis? Cases where you have multiple differential diagnoses, or where symptoms and tests are ambiguous or confusing, represent the highest levels of difficulty. Those cases have the greatest chances for incorrectly treating the case with endodontics, or even worse, treating the wrong tooth. If you're not sure of the diagnosis, consider referral. The second consideration is radiographic. Do your radiographs confirm your diagnosis and show the clinical situation clearly? Are your films diagnostic in quality? And if they're not, consider retaking them with a better technique that clearly shows you the tooth, the apex, and the associated areas. No cone cuts, no cutoff roots, no poor angulation or distorted images. You need to see the tooth well in the radiograph in order to evaluate the difficulty. Cases in which there is difficulty in interpreting the radiographs where canals are indistinct or poorly visible, or where it's difficult to obtain a good image, such as with the big mandibular tori or a heavy gag reflex, represent the highest levels of difficulty. In many cases, two-dimensional imaging is inadequate. 3D imaging with a CBCT has become the endodontic standard, and it will frequently show problems not visible with conventional radiography, as well as giving us a much better understanding of the root and canal anatomy and shape. The ability to position the patient in the chair and oral opening are also of major consideration. Patients who are elderly and cannot be reclined, or patients with TMJ issues that have minimal ability to open, all represent the highest levels of difficulty, especially in the posterior area. What is the position of the tooth in the arch? Anterior and premolar teeth are generally more accessible, but as we move toward the more posterior areas of the mouth, access to the occlusal surface becomes more difficult. We also have to consider inclination of the tooth in the anterior teeth and position of the tooth in the arch and degree of rotation. Inclination and rotation of greater than 30 degrees is generally considered to be of higher difficulty. Tooth isolation is also a consideration. How easily can the rubber dam clamp be applied to the tooth to allow for proper isolation? What are the chances of the restoration and loosening where the tooth or cusps fracturing during treatment? Is a buildup or banding needed for this tooth prior to initiation of treatment to allow for secure rubber dam placement during all aspects of the treatment? What's the coronal morphology? Is the normal coronal morphology present, or has the tooth been restored with a full crown restoration that may be significantly deviated from the natural axis of the tooth? What is the root morphology? What level of curvature does the root have? Cases with lower difficulty generally have slight or minimal curvature. Moderately difficult cases have curvatures of 30 degrees or less. Cases with root canal curvatures and root curvatures of 30 degrees or more, C-shaped morphology, or S-shaped curves represent higher than normal levels of difficulty. Other anomalies such as three-rooted premolars, long teeth, or teeth with open apices all represent the highest level of difficulty. What about the chamber and the canal morphology? Is the chamber easily visible, or is it obscured by a restoration or a crown? How easy will it be to make access into this tooth? Is there significant calcification of the chamber and canals? Is the canal even radiographically visible? Indistinct chambers or canals represent the highest levels of difficulty and potential for broken instruments, perforation, or clinical errors. Does the patient have a history of traumatic incident which may have resulted in fractures of the root, incomplete root development, resorption, or calcific obliteration of the chamber and canal space? It's sometimes better to consider surgical treatment of these calcified teeth rather than hogging out a tooth in the hopes of finding a canal. Again, all of these factors contribute to the classification of the tooth as having the highest level of difficulty. What is the position of the root apex vis-a-vis the rest of the anatomical structures? In maxillary molars, are the roots located inside the sinus? In the case of mandibular posterior teeth, how close is the apex to the mandibular canal? What is the proximity of the premolar apex to the mental foramen? Has pathology affected the root anatomy? Has chronic apical periodontitis resulted in root resorption that has altered the root shape, the canal, or the foramen to the point where it may present difficulties with obturation? Lastly, what are the patient's expectations, and how likely are you to satisfy their needs? How strategic is the tooth? How will the patient respond should things not go as planned? If the treatment fails, or if at some point referral to an endodontist is necessary in the future. There's nothing more frustrating for an endodontist than having a referring dentist work on a case and then decide that they need to refer the case after running into problems. These teeth often have over-enlarged access, ledged canals, broken files, perforations, and other procedural accidents that make it almost impossible for the endodontist to obtain the ideal clinical results. We should treat patients as we wish to be treated ourselves. That means accepting the limitations of our clinical skills, regardless of the financial pressures or a patient's reluctance to see or travel to a specialist. Proper case difficulty assessment and referral, when necessary, is part of good clinical practice. The best rule of thumb is this. If this was your mom or your spouse, would you be doing the endo? Remember, when we do the right thing, we both get better, patients and clinicians. Thank you for joining me, and I look forward to our next trip when we go beyond the terminus.